All right, I'm gonna get started. Good morning, everyone. I'm Herod, for those of you that don't know me. This is a pre-hospital disaster medicine lecture, specifically on burn MCIs. So special thanks to the disaster medicine team for helping me with this. I think burn by Usher also would have been appropriate here, but got my point across. These are my objectives. We'll get through them at some point throughout the lecture. So to start off, just kind of go through like a scenario. Fire and EMS get dispatched to a 2-alarm fire in an apartment building. So multiple patients with various different presentations being assessed in the surrounding area, and the appropriate way to kind of sift through that and create like an incident command. Fire and EMS are able to use either SALT, which stands for Sort, Assess, Life-Saving Interventions, Treatment, Transport, or START, Simple Triage and Rapid Treatment. Helps them establish the incident command, begin rapid triage of patients. The importance of which they decide to use helps minimize confusion during a large-scale incident, and it's important that everyone's using the same system. After this, they kind of have to determine where the patient needs to be transported in order to receive the proper care. In order to transport patients specifically to a burn center, the American Burn Association has created guidelines. Ideally, each patient with a significant burn injury would be sent directly to a burn center, although this is unrealistic given the scarcity of such facilities and potentially significant transfer times in many areas of the country. Factors for EMS to consider when choosing an appropriate destination should include patient stability, as unstable patients should go to the nearest emergency department before transfer to a burn center. You have to also keep in mind age, size, and depth of the burn, other traumatic injuries, and so on and so forth. So there are 10 designated burn centers in New York State, 4 of which are in the New York City region. Between all of them, there are only 71 burn beds for the entirety of New York City. A large apartment complex with dozens of victims can quickly overwhelm the system, and New York is very vulnerable to a large-scale fire MCI. 2017, Dr. Daniel and Dr. Kohlhoff actually looked at the lack of burn centers in Brooklyn during a burn MCI kind of mock process, and they realized that transferring patients to appropriate centers for care gets delayed due to a patient transfer request form being too lengthy, and utilization during the MCI was being amended using the information used by their study. They concluded that due to the lack of beds and difficulty transferring, non-burn centers need to develop their own contingency plans for the possibility of an MCI. It's been shown also in academic reviews that distributing burn victims to non-burn centers for stabilizing treatment in lieu of direct transport does not significantly alter the mortality of the victim. So with this understanding, EMS in our scenario determined that multiple patients are too unstable and they're going to take them straight to Kings County. So our first patient is a 35-year-old male rescued from a smoke-filled hallway, hoarse voice, audible stridor, facial burns around the nose and mouth. We have our second patient, 28-year-old female evacuated from the 5th floor, normal vitals, but reports headache, nausea, vomiting, slightly confused, but no obvious burns. Patient 3 is a 50-year-old male found unconscious on the ground floor, large burns across the torso and legs, hypotensive, tachycardic. And patient 4 is a 40-year-old female, escaped from the lobby, superficial burn on the forearm, no respiratory symptoms. There's no like set answer in this, but does anyone have a patient of the 4 that they would take first, second, kind of like triage on their own?
Given like I don't know if the individual patient is airway at this moment. I feel like patient 1 was like airway intervention. Hospital first for me.
Yeah, I think that's fair. Patient 1 is the airway emergency. So that kind of brings up the point of, the hospital kind of getting overwhelmed by this influx of patients and the importance of secondary triage that, we'll have to rapidly be doing at the ER ourselves. So all these patients arrive at the same time. It's important to understand the continuation of the triaging that occurred to bring these patients in from the MCI. So you have to prioritize patients, who should be treated first and why. How do you balance immediate airway threats versus systemic toxicity or extensive burns? You have to bear in mind transfer considerations since we're not a burn center, which patients require emergent transfer, what stabilization steps should we take, and then ultimately, how do you manage limited resources during a mass casualty event? I always think back to where I went to med school in Vegas, where they had kind of like one of the worst shootings. they actually ran out of vents and they had to find patients that had equal kind of body sizes that would have similar vent settings and have them share the vent through T-tubing. So these are things that you can't necessarily always account for, but you have to keep in mind. So initial priority is to always make sure the scene is safe for yourself. Knowing the cause of the fire, whether chemical or otherwise, determine what PPE you need to use and proper decontamination if required. Burn patient management, the most important step is stop the burning process, remove the patient, electrical, dry chemical dusting, liquid chemicals through irrigation. It's typically done in the pre-hospital setting, but there are possibilities of patients still being transported with like smoldering clothes, different substances still possibly on their articles of clothing. So it's essential to gather any known information about chemicals involved, duration and type of exposure. Otherwise, once the risk of immediate ongoing burn injury is addressed, you should take a systematic approach to patient assessment like we always do. So as with most cases, patient assessment begins with a primary survey focused on airway patency, breathing, circulation. Following the support of the ABCs, a thorough secondary assessment should be performed and do a head-to-toe assessment to identify all burns and other traumatic injuries. So patients with inhalational injuries may present with singed nasal hairs, carbonaceous sputum or debris, cough, hoarseness, stridor, retractions, different reasons to suspect an inhalational injury and then ultimately decide to intubate. Smoke inhalation is the leading cause of fire related deaths according to death certificate analysis. This is a little outdated. It was in 99. However, smoke itself composed of particulate matter, heated gases, irritants, asphyxiants, different toxins. The thermal insult to the upper airway may produce edema, bronchospasm, airway occlusion, decreased chest compliance. Ultimately, when you're intubating these patients, the goal is to use the largest caliber ET tube possible because you'll have progressive airway edema and mucosal sloughing. So you can then begin to, categorize the burns that you see. There are first degree burns, superficial burns. They usually affect only the epidermis or the outer layer of the skin. It's usually red, painful, dry, no blisters. Be moderately painful, but they usually heal without scarring in about 5 to 10 days. Sunburn is the most common example. Long-term tissue damage is generally rare, and it consists of increase or decrease in the skin color, depending on the location. Next, you'd have partial thickness or second degree burns. They have superficial and deep classifications. So a superficial partial thickness burn affects the epidermis and the superficial layer of the dermis. Blisters are much more common here. Once the blister is unroofed, the underlying wound is usually homogeneously red or pink, and it will blanch with pressure, which is important. Could be swollen. These are typically painful, and they take a little longer, closer to 2 to 3 weeks to heal. The deep partial thickness burns involve the deeper layers of the dermis. They're similar to the superficial partial. They can also present with blisters. This one will show a little bit more kind of like modeling and sluggish to blanch once you deroof the blisters. Otherwise, these burns can heal without surgery, but it does take longer, and typically scarring is unavoidable. The last is the third degree or full thickness burns. They are the most severe. They affect the dermis, epidermis and dermis layers. They also extend into subcutaneous tissue, may damage the underlying bones, muscles, tendons. That's in some areas classified as fourth degree. I couldn't find a clear distinction. These burns result in leathery, stiff, and dry appearance. They can often appear white or charred. At this depth, it doesn't blanch due to the compromised blood supply. The nerves are also damaged, so it's typically not initially painful, and they take upwards of 8 weeks to heal with like surgical revision. So something to consider is in the event that thoracic burns are circumferential, an escherotomy can be considered to attempt to increase thoracic compliance to allow for ventilation. This, kind of falls under secondary survey, but in the immediate, when you're still dealing with airway, breathing, circulation, sometimes this can present as increased airway pressures on a vent or reduced O2 sats due to the lack of compliance. They can cause peripheral arterial occlusion, kind of like compartment syndrome, and tracheal compression as well. The pressure needs to be released in a fasciotomy-like process. It could be conducted in a non-sterile fashion at the bedside. So moving on to circulation. IV access, you always want to get 2 large bore IVs, preferably through unburnt tissue. Peripheral circulation should be checked throughout the body. Any deep or full thickness circumferential extremity can act as a tourniquet, especially once the edema starts to develop a little bit later after fluid resuscitation. So it's important to bear that in mind that it may not happen immediately, but it could happen hours after the burn. If there's any suspicion for decreased perfusion due to the burn, keep in mind kind of that escherotomies are something in our purview as well. It's important to it's important to remove all clothing, jewelry, and watches because when the edema develops, those can act as tourniquets and become restrictive and cutting off blood flow and circulation. And while removing clothing, it's key to protect the patients from hypothermia. The injured tissue of a burn patient loses its ability to protect thermoregulation, and it leaves the patient at high risk for hypothermia and associated complications. So initial volume resuscitation is with crystalloid solutions, primarily LR, and that's because membrane permeability is thought to resolve eventually within the first 12 hours. So major burn injuries result in an area of necrotic tissue, and below this is a zone of stasis that results in the release of inflammatory mediators like histamine, prostaglandins, increased capillary permeability, and lead to localized burn and wound edema. Patients may experience massive interstitial fluid shifts and are at risk for intravascular hypovolemia, which then in turn reduces cardiac output and causes an increase in systemic vascular resistance. The resuscitation regimen should be determined and begun based on the estimation of the burn, which we'll get into how to do that. Typically, these patients need a urinary catheter placed, especially when they have burn areas covering greater than 20% of the total body surface. And there's various ways to determine how to properly resuscitate these patients. The most common one is the rule of nines or the Wallace rule of nines. It's a tool utilized by medical providers to estimate the total body surface area involvement in burn patients. The measurement of the initial burn surface area is important as they will have insensible fluid losses due to the lack of a skin barrier. So it's kind of categorizes the body in different variations of nines. So the entire head is 9, whereas the front and back is 4.5%, similar to the arm. 9 front and back are 4.5%. The leg is a little bit larger, obviously, so the front and back are each 9%, and then they subdivide the torso and into the chest and abdomen as 9, 9, and then the back as well. So these calculations can only be used for second and third degree burns, not for first degree burns. The concern among clinicians is the accuracy of this rule of nines kind of varies based on provider subjectivity. This concept becomes more problematic with larger burns and in obese and pediatric populations. The discrepancy also becomes larger with less experienced providers. So the shortcomings has kind of been documented progressively since the 80s. Studies have shown that burns that cover about 25, 30, or 35% of the total body surface area are often overestimated by 20% when compared to computer calculated algorithms. So it could lead to excessive intravenous fluid resuscitation, volume overload, pulmonary edema, increased cardiac demand. So they can be further exacerbated if fluid resuscitation is strictly determined using these formulas without considering the patient as an individual or different burn characteristics. It's still kind of, as far as the formulas go, the most accurate way for patients between 10 and 80 kilos. There is also the London Browder, kind of where the rule of nines falls short is, like I said, with the obese and pediatric populations. So what the London Browder does is it takes into consideration the age of the person with decreasing percentage for the head and increasing percentage for the legs as the child grows up, and it's more useful for pediatric populations. You can also use the Palmer method for smaller burns. So essentially, it's an easy way to get a rough estimate. You measure from the patient's wrist to the tip of their fingers, and it's important that it's theirs, not yours. And that counts for about 1% of the total body surface area. But studies show that even this can overestimate for about 10 to 20%. So once you've figured out the body surface area that's been burnt, you need to direct how you're going to do your fluid resuscitation. So the goal is to maintain tissue perfusion in the early phase of burn shock, in which hypovolemia finally occurs due to steady fluid extrav from the intravascular compartment. So typically you want to use this when there's greater than 15 to 20% body surface area involvement. The several formulas exist. The most common one is the Parkland formula, and it kind of helps guide fluid resuscitation in the first 24 hours. So in the initial 24 hours, you use LR. It's about 4 milliliters per kilogram for percent burned for adults, 3 for children. And this is added to maintenance fluids, as the formula doesn't account for maintenance fluids, so you still use the 4-2-1 rule in addition to the calculation from this. The next 24 hours, they give colloids as about 20 to 60% of the calculation of the plasma volume, no more crystalloids. Glucose and water can be added to maintain the urinary output to 0.5 to 1 milliliter per hour in adults and then 1 milliliter in children. So there's no contraindications to using this for patients with comorbidities like heart failure and end-stage renal disease should be closely monitored. But ultimately, you need to kind of use this with the direction of the resuscitation, not necessarily just using this as this is how I'm going to do it. You need to keep in mind how the patient's reacting to the fluids. So another one is the Brook formula, which is notable because it uses slightly less fluid per the formula. However, a 2023 study found that neither the Brook or the Parkland formula reached 85% accuracy for burn resuscitation. And I thought something that was surprising was the lower fluid volume used in the Brook formula in comparison to the Parkland formula actually resulted in more over resuscitation in the study that was conducted, which I thought was interesting. So goals for fluid resuscitation are generally accepted as urine output greater than 0.5 milliliters per kilogram per hour, base deficit less than 2, systolic blood pressure greater than 90, and clinically with peripheral pulses that are palpable and no altered mental status. Although studies have shown these variables to be adequate predictors of fluid resuscitation, many have relied solely on just urine output. It's found that vital signs in urine output did not appreciably change after volume repletion. And so these measurements can ultimately lead to pulmonary. These measurements did not change while the pulmonary artery catheterization showed significant changes. Urine output is regarded as the resuscitation goal in pediatric burn management, but also similar to adults, you just have to keep in mind that can't be the sole measurement you're using. So another thing to bear in mind when you have these burn MCIs is the combustible materials that are being burned causing the fire. So often you can find people with carbon monoxide poisoning. It's a colorless, odorless, poisonous gas that comes from burning fuels such as wood, oil, charcoal. Common cause of accidental poisoning in fires, but also a common cause of intentional self-harm. So carbon monoxide binds to deoxyhemoglobin 40 times the affinity of oxygen, binds to intracellular proteins, particularly the cytochrome oxidase pathway, and it leads to intra and extracellular hypoxia. The symptoms can include altered mental status, decreased responsiveness, headache, nausea, vomiting. Patient may exhibit continued symptoms of hypoxia despite a potentially normal SpO2, as pulse oximetry can't differentiate between the oxy and carboxyhemoglobin. Blood gas will reveal metabolic acidosis and raise carboxyhemoglobin levels. Ultimately, high flow oxygen should be administered to these patients because the half-life of CO is reduced from 40 to 60 minutes in the presence of high flow. One of the treatments to bear in mind for this is hyperbaric oxygen therapy. The decision to treat with hyperbaric oxygen can be controversial, but most experts agree that if there's loss of consciousness, either at the scene or at the hospital, if there's new neurologic deficits or mental status changes, if there's signs of end organ ischemia, such as EKG changes, low pH, or if the patient's generally pregnant, but mostly with a carboxyhemoglobin of more than 15%, then treatment's indicated. You don't only treat based on how high the carboxyhemoglobin is. You have to always correlate the clinical symptoms, but the general consensus is higher than 25% in standard patients or 15%, like I said, in pregnant patients, then treatment's justified. It's reasonable to err on the side of treating patients because it's difficult to predict who will go on to develop the delayed neuropsychiatric syndrome or DNS, which is a significant problem in about 40% of these patients. Ultimately, this syndrome can arise in about 20 days after poisoning, but the range is anywhere from 3 to 240 days, so it's really hard to kind of predict that. Manifests as cognitive deficits, personality changes, movement disorders, and focal neurologic deficits. The deficits usually resolve after 1 year, but can be permanent in some cases. It helps reduce the risk of DNS by helping with the ischemia reperfusion injury in the central nervous system. The mechanism is to not only cause more rapid displacement of the carboxyhemoglobin from the hemoglobin, but to generate normal oxyhemoglobin in the red blood cell. Typically, it's delivered most beneficial if it's within the first 6 hours after exposure. And then also important to bear in mind that some of these patients could present with cyanide toxicity. So hydrogen cyanide is a product of the combustion of plastics, not necessarily through the actual fuel that's being burned to cause the fire, such as the carbon monoxide. Cyanide's main effect is that it inhibits oxidative phosphorylation, where oxygen is utilized for the process of intracellular energy in the form of ATP. It also does so by binding the enzyme cytochrome C oxidase and blocks the mitochondrial transport chain. So the clinical manifestations of this can be divided into early and late categories. You could have symptoms such as headache, dizziness, confusion, mydriasis. It happens due to tissue hypoxia and can cause seizures and coma as it develops into the later stages. Patients will not be cyanotic typically, but they will have a cherry red color due to excess oxygen in the bloodstream. The key decision in management of cyanide poisoning is also timely, similar to the carbon monoxide. You have to select the antidote early on. A severe metabolic acidosis with increased anion gap is expected in this poisoning, and cyanide levels may be obtained, but that lab usually is delayed, and by that point, it's kind of too late to begin the treatment. So the treatment of choice is hydroxycobalamin. It's often preferred as the current therapy as the bound cyanide is renally excreted in the form of cyanocobalamin, which is non-toxic. It's now used primarily over sodium thiosulfate, which is associated with the formation of methemoglobinemia and can cause and can potentiate decreased oxygenation. So the dose of it specifically is 70 mg per kg. It's given typically 5 grams max dose for adults in the cyano kit. It's done IV, and it's given to it's the effective dose for a majority of these cyanide exposures that occur by inhalation. In looking into this research, I saw a review that had been done by Dr. Dukas that cyano kits are not readily held in hospitals, especially in Brooklyn. I think there were only 2 hospitals that are prepared to handle more than 5 patients that present with cyanide toxicity. It's typically held by EMS and FDNY, and during these large fire incidents, they will deliver it to hospitals or to the patients themselves. But I spoke to an FDNY representative, and there's a bit of point of contention between who's funding the reserves for these cyano kits because they typically expire after 2 years. So it's like hospital versus FDNY and who's going to actually be taking care of these patients. Another interesting thing is in pregnancy, the hydroxycobalamin does pass into your breast milk, something to bear in mind. And then pediatrics have limited data available. So the recommended dose is still 5 grams for them, from what I could see. Ultimately, these burn MCIs are complex logistical and clinical issues that extend beyond the depth of this lecture. It's important to bear in mind considerations outside of just airway, body surface burns, carbon monoxide, and cyanide. Because of these complexities, a sudden surge in patients with critical burn injuries require immediate and prolonged care following a burn MCI and will place immense stress on the healthcare system. Showed in the first 120 minutes, the greatest constraint is the number of beds. It starts with the critical care beds, and then obviously the floor beds. So as we notice that happens in the pods, it's going to really fall on us to kind of continue triaging patients, often like how it happens in CCT. When we admit a patient, that doesn't mean we're done caring for the patient. They're going to still be in our hospital, in our ER, under our care. Disaster preparedness and careful planning to maximize the efficient mobilization and rational use of burn care resources is essential to limit morbidity and mortality following a burn MCI. And that is my lecture. Here are references, image citations.